Right, so Bhaswati, we are actually doing ISTENTs here now for the last 9 months. And yes, that was the very first ISTENT that was implanted in India in September last year. So I have 9 months follow-up for this particular patient, and I'll give you the history of that patient. You will be amazed. So I'm going to talk about ISTENT and ISTENT Inject. We have not, Glaucos has not introduced W yet for us, and then of course Infinite is still in the pipeline, and iStent Supra is also undergoing clinical trials at the moment. So they have reclassified it as a trabecular micro bypass system. These are my disclosures. So just to recap, I'm sure you've gone through a lot of presentations throughout this conference, but basically MIGS was something that was, the term was coined in 2012. I have done my fellowship with Dr. AIOC2022 in Toronto in Canada. He was one of the key individuals instrumental not only in coining this term, I think in collaboration with Glaucos, but also looking into the research and development of many, many more. So basically, these surgeries cause minimal trauma to the target tissue. They definitely reduce your operating time. They do have modest efficacy. You cannot compare it with trabeculectomy. It is not here to replace trabeculectomy, and I quite agree with Bhaswati there. It has a very high safety profile, and there is rapid recovery. It's almost like phaco. Patient recovers vision within the week. In most cases, in a few cases of GAT, they may have a little bit more hyphema and may require an AC wash. So basically, conjunctiva and sclera are spared. There is no bleb formation, so there is no worry about hypotony or bleb-related problems. It acts by bypassing the trabecular meshwork, and it reduces dependence on anti-glaucoma medication. So these are the key factors that one has to remember about iStents. Now, iStents are one of the smallest devices known to mankind. When iStent first came out, and this is now called G1, generation 1, this was just about 1 millimeter in length and 0.3 millimeter in height, and of course has both FDA and CE approval. But the most important thing I feel is that about all these surgeries is that it spares the conjunctiva. So in future, ever you require trabeculectomy, it is never contraindicated. Then the next generation, G2, that came through is the iStent Inject. Now this has become 1/3 the size of an iStent G1, and its height is 0.3, its width is about less than 0.3. So then came the iStent W, where the height and the width are the same. So that's the modification, so that there is no over-implantation. So this is a modification, of course. And it comes preloaded with 2 devices. There is no right or left stent, unlike the G1 devices. So here we are. These two, I will show you ex vivo, how they work. iStent works by a maneuver which is parallel to your trabecular meshwork. So you insert it parallel to your trabecular meshwork. It's actually pretty easy to do if you know how to do intraoperative gonioscopy. It actually gives you quite a bit of a high, quite a bit of a buzz. That's iStent, and iStent Inject is basically a perpendicular injection. So you create a dimple onto the trabecular meshwork and inject and release. That's it. It's as simple as that. Actual procedure does not even take 5 seconds, believe me. So what is the difference between iStent and iStent Inject? There are 2 stents with iStent Inject. Both come preloaded, and it is relatively easier implantation because it removes the manual variable. There is no right or left. So with the iStent G1, I prefer the left orientation. I don't like the right orientation because that is backhand. So, these are small issues. Here's a video. You will see that you have to visualize the angle at high magnification, introduce your device, increase the magnification again after having decreased it, and implant your device in the trabecular meshwork, and that is exactly how long it takes. 5 seconds, unedited video. When you see blood regurgitating, that's an excellent sign because it means you're in the correct position. Here you can see that the retention arches are well embedded inside the Schlemm's canal, and you have a snorkel which is proud of the surface of the trabecular meshwork. Unlike the ISTENT, which, sorry, the next one now. Unlike the ISTENT, which INJECT, which should be almost flush with the surface of the trabecular meshwork. Here we are, 2 being implanted. The first one, here, slight dimple of the trabecular meshwork, and then you inject and you withdraw in the same plane so that you don't disturb. You tap it a little bit and you make sure that it is in position. You don't see a regurgitation there, I do notice that. I like to withdraw it out of the eye, reposition myself, and then go back in, and this video I borrowed from a co-fellow from Toronto, and he prefers to do the same. So here we are, the second one also, little bit eccentric, I felt. Nonetheless, it's now flush with the trabecular meshwork. So how does it work? It creates a micro bypass through the trabecular meshwork, providing a direct channel between the Schlemm's canal and the collector channels. Everyone knows that it's the juxtacanalicular meshwork that creates the maximum resistance. So it bypasses that. Huang et al. Did a really excellent work by doing anterior segment angiography of the aqueous veins to show pre and post ISTENT angiography. Before the procedure, you can see that there's very little flow through the aqueous veins, collector channels and aqueous veins. But after placement of 2 devices, you can see that the channels which appeared to be dormant have opened up. So it has the potential to re-establish flow in previously dormant outflow channels. Also, it increases the facility to lower resistance to outflow. Now, this is also another very elegant work by Cindy Bala et al., much before Alex Huang came up with their angiographic one, where they have found that with 1 ISTENT, you double the outflow facility, and if you put 2, you actually make it 5 times. So it actually works. Here you can see that there is dilatation noted around the ISTENT inject head. This was again an ex vivo study, it wasn't an in vivo study. So what are the indications? They are mild to moderate, primary open angle glaucoma. This is the mandated, but as you know, we all are trying to do in various different types of glaucoma. However, one needs to classify the glaucomas on visual fields. They are mild to moderate only on visual fields. It could be open angle, pseudoexfoliative, whatever. Also, you can do it in phakic patients. You don't necessarily have to combine iStents with cataract surgery, but you can, of course, do. You can do it in pseudophakic patients. You can do it in patients who have difficulty taking medication, who have side effects or complications to these, or, as we all know, are poorly compliant patients. I will not go into details about all the studies that have been published because, again, going through the various presentations, I found that many people have talked about many, many studies, but I will talk about this systematic analysis, meta-analysis, which has shown, a long-term one, which has shown a very consistent decrease of about 30% in intraocular pressure from baseline, and also reduction of medication, and that over 60 months, only 2.6% of the eyes of all the studies that were included required filtration surgery after that. So what are the complications that you can expect? Not a long list at all. In fact, I had to scratch my head to find some. Iris endothelial touch, well, that is something will decrease with experience. Over or under implantation, you have maneuvers that are available to correct these. There can be stent malposition. You may have to withdraw and reposition. Sometimes you can have occlusion, which you can observe or can consider doing a YAG laser. Sometimes you have hyphema, but I have not come across it so far, and if it happens, it's usually transient and self-resolving. Late post-op, need for glaucoma filtration surgery is only 4%. Compare this, and we keep saying this, compare this with the long list of complications that can happen with trabeculectomy or even with drainage surgery. And I feel one of the least talked about complication of trabeculectomy is bleb failure. It is a complication of the surgery. And one has to look at it, these are all failed blebs, failing or failed blebs, and blebs that are predisposed to infection, lifetime of infection. Depends on which literature you're reading, but basically it can vary from 0.4 to 6.9%. Here's a patient who, fairly young, 55-year-old, who had pressures running in mid-40s, for whom I had to do a trabeculectomy because at that time, ISTENT was not available in India. Lo and behold, he works in an oil field in Duliajan, Assam, off the coast. And he came back to me with blebitis. He was fortunate enough to recover not only vision, but also his filtration without any medication, but not every patient is that lucky. Complications in glaucoma drainage devices, again, those that are common for all subconjunctival filtrations, and there are certain unique ones that are common to all types of GDD. You have tube exposure, plate exposure, you have tube endothelial touch, you have tube block, you name it, you have it. So I just want to present to you a real world experience very early, in our country for related to eye stents that have been done by these 4 surgeons. Follow-up, as you know, because it's very, very early, it's only 4 weeks. They were all combined with cataract surgery, all open-angle glaucoma, and they all had high medication burden, either intolerance and or allergy. So we started with a pressure of almost 20, anti-glaucoma medication of 3.8, and we ended up with, we're still studying it, 14.4 and 1.8 medication. That translates to about 27% reduction in IOP and 52% reduction in medication, which was all statistically significant. I present to you the first case of iStent that was done in this country. He was a 61-year-old gentleman who had actually already undergone trabeculectomy. And not just trabeculectomy, he had undergone needling 3 times. Post-surgeries, slowly, over a period of time, 5 years, he needed 5 topical medications to control his IOP, and he subsequently developed severe intolerance to these medications. His preoperative IOP was 22 millimeter mercury in the right eye on 5 anti-glaucoma medication, and because these medications were withdrawn, the offending medications were withdrawn in the left eye, his pressure had shot up to 29. And he was mild to moderate in both eyes, although he was progressing in the right eye. So this is his intolerance. You can see the changes in the conjunctiva. And a phaco eye stent was done for him in September 2021, and the left eye was done in January 2022. And post-operatively, now 9 months in the right eye, 6 months in the left, almost. We have visual acuity of 6.6 N6 and intraocular pressure of 17 on 2 anti-glaucoma medications in the right eye and 18 without any medications in the left eye. So this is what he looked after anti-glaucoma medications were taken off, but have a look now. This is the middle one is when anti-glaucoma medications were taken off, and this is how he looks now without any medications or only minimal medications in the right eye. So this was the video of the very first iStent done in this country. I had a few challenges in terms of my video equipment, but you know, I think the majority of it we have managed to capture. Again, you have to have an en-face view of the trabecular meshwork. And that is where your good technique of intraoperative gonioscopy is extremely important. And you slide it in as a parallel action, and you release. After this, unfortunately, my video conked off. But there you are. The view always should be clear, view of the angle. So I leave you with a few tips for performing a successful MIGS. Please remember, preoperatively, you have to counsel with respect to the patient expectations. You cannot tell them that, you know, you're going to have fantastic pressures, and we're going to stop all medications. That may be possible, but it's not always possible. So you have to counsel with respect to their expectations. Stop antiplatelet drugs, very, very important. You do not want hyphema, any kind of bleeding when you're doing the surgery. There should be a conscious, pre-planned, pre-procedure practice of intraoperative gonioscopy in phaco cases. In your routine cataract surgery, you can change the position of the patient and the microscope, take an intraoperative gonioscope, and just do it. It just takes 2 to 5 minutes to complete, and it will give you greater confidence when you actually take up the surgery. You have to have awareness of different types of intraoperative gonio lenses, and you have to be able to visualize the angle under high magnification. And I would suggest that you use a Sinskey and go right up to the trabecular meshwork, get a feel of the trabecular meshwork. So just showing this in a few steps. This is Schwann-Jacob, and this has been widely used in you know, not just in India, worldwide. I have it because I did my pediatric goniotomies with it, but I find that the view with Schwann-Jacob, now that there are many more lenses available, is not that brilliant. As you can see, you know, in that particular case, of course, there might be a problem with the capture also, but even here, when there is no problem, you know, there is problem with capture, you can see the trabecular meshwork far clearer with this lens. This is an iPrism S. It's a disposable lens, and this one is a very different type of lens. It's called iPrism SX. It's vertical, and you do not need to hold it. It stays put on the cornea. So your left hand is actually free. When your left hand is free, then there is no chance of you causing corneal indentation and loss of clarity. That is very important. And what you see with these in terms of brightness and in terms of clarity is way, way better than Schwann-Jacob. That's my personal opinion. People might differ. Then positioning of the patient and the surgeon. Surgeon, it is better to sit temporal because you want to target the inferonasal quadrant first. If you're doing an ISTENT inject, you can reposition yourself. Microscope positioning, about 30-35 degrees. Patient positioning, about 30-35 degrees. So here we are. You need to measure where you are. So microscope towards you. This was my training before my first case. And so you make sure that the microscope is turned towards you and the patient away from you, about 30-35 degrees. And create phaco wounds that are slightly anterior to the limbus. You do not want bleeding from peripheral vessels all the time. That also reduces your view. So I would suggest you go into clear cornea a little bit, as much as possible. And as you can see here, there is no bleeding when that wound is made. Then, like I said, practice of intraoperative gonioscopy in phaco cases under high magnification with Sinskey to the trabecular meshwork. This case is that of an angle closure who opened up after laser peripheral iridotomy. And I'm just using a Sinskey hook to show you all the minute synecdoche that had formed for this particular patient. So to summarize, MIGS are usually ab internal, minimally traumatic, safe procedures with which preserve the conjunctiva. It fills the void between medical management and more invasive traditional surgery. So medical management, till they are managed, it's good. But if they are mild to moderate and they are not controlled, then you can move on to MIGS procedures rather than trabeculectomy. So it is bridging. It's bridging that gap, which is exactly what Bhaswati was talking about. ISTENT and ISTENT Inject are two of the smallest devices known to mankind and helps to bypass the trabecular resistance and improve facility of outflow. Mostly indicated in OAG, that is what it has been mandated for, mild to moderate glaucomas. In initial footprint in India is a little varied. We have used it in advanced glaucomas also. In controlled and uncontrolled, moderate, mild, moderate, and one or two severe cases in our series, it has reduced pressure to about 27%, medication 50%. And inevitably, cost may be a limiting factor. Thank you very much.